Total intravenous anesthesia, TIVA. TIVA is a type of general anesthesia where all the drugs are given through the vein, no gas is used. It gives sleep and pain relief using IV drugs only, usually propofol to make the patient sleep and remifentanil to control pain. It is preferred because it gives smooth sleep and smooth wake up, less nausea and vomiting, no pollution from anesthetic gases, and it is safe for patients who cannot have gas anesthesia. TIVA is very useful for brain surgery, short-day cases, patients at risk of malignant hyperthermia, and want a clear airway without gas. Total intravenous anesthesia, TIVA. Theme: a practical, safety-first framework for modern TIVA. To provide a structured, safe, and standardized approach to delivering TIVA in clinical practice. Key pillars. 1. Propofol. Main hypnotic used to maintain unconsciousness. To produce and maintain sleep with rapid onset and smooth recovery. 2. Remifentanil. Ultra-short-acting opioid analgesic. To provide intense, controllable pain relief and blunt sympathetic response to surgical stimuli. 3. Target-controlled infusion, TCI. Computer-driven infusion system using pharmacokinetic models to achieve desired drug concentration. To allow precise, predictable dosing and stable anesthetic depth. 4. Processed EEG BIS, monitor of anesthesia. To prevent awareness, avoid overdosage, and guide titration. Learning objectives. By the end, participants should be able to 1. Define TIVA and distinguish manual infusion from TCI. 2. Select drugs, models and monitoring appropriately. 3. Build a reliable infusion and troubleshooting plan. 4. Reduce awareness, hemodynamic instability and dosing errors. What is TIVA? General anesthesia maintained exclusively with intravenous agents, usually a hypnotic plus an analgesic. To achieve unconsciousness and pain relief without using inhalational gases, relying only on IV drugs. Core concept. Drug delivery is only as reliable as the vascular access, pump, tubing, programming and monitoring behind it. To emphasize that any failure in the infusion system can cause awareness or overdose, so the entire delivery chain must be secure and checked. Why choose TIVA? 1. Lower PONV risk in many patients, especially with propofol-based techniques. To improve patient comfort, reduce need for antiemetics, and enhance recovery especially in high-risk patients. 2. Useful when volatile delivery is undesirable or impractical. To provide safe anesthesia in cases like malignant hyperthermia risk, neurosurgery, or where volatile agents are contraindicated. 3. No operating room volatile exposure or exhaled anesthetic gas. To protect theater staff from occasional exposure and reduce theater pollution and environmental impact. 4. Smooth, titratable emergence with short-acting drugs. To allow rapid adjustment of depth and a calm, predictable wake-up with short-acting agents. Trade-off. No end-tidal concentration. Delivery failure can rapidly become awareness. To highlight that unlike gases, there is no exhaled concentration to monitor, so any disconnection or failure can quickly lead to awareness if not detected early. The TIVA mental model. 3 linked targets. 1. Hypnosis, unconsciousness, amnesia. To ensure the patient is asleep and has no recall of surgery, mainly achieved with propofol. 2. Analgesia, response suppression, antinociception, block pain response and blunt autonomic response to surgical stimulus, mainly with remifentanil. 3. Immobility, surgical conditions, often with NMBA. To provide optimal operating conditions and prevent movement, often requiring a neuromuscular blocking agent. Key principle: titrate each component deliberately rather than escalating one drug to solve every problem. To maintain balanced anesthesia, avoid overdose of a single agent, and achieve stability with fewer side effects. The core pharmacology. Propofol. 1. Hypnotic, rapid onset and recovery. To produce quick unconsciousness and allow fast, clear wake-up due to rapid redistribution and metabolism. 2. Dose-dependent hypotension, apnea and bradycardia. To note that higher doses depress cardiovascular and respiratory systems, so titration and monitoring are essential. 3. Antiemetic properties, pain on injection. To reduce post-operative nausea and vomiting, but may cause discomfort on injection requiring novocaine or larger vein use. Remifentanil. 1. Ultra-short context-sensitive recovery. To allow rapid offset regardless of infusion duration because it is metabolized by plasma esterases. 2. Potent, rapidly titratable analgesia. To provide intense pain control that can be quickly adjusted up or down to match surgical stimulus. 3. Post-infusion hyperalgesia and respiratory depression are possible. To anticipate increased pain sensitivity after stopping and risk of hypoventilation, requiring careful monitoring. Note: add multimodal analgesia before stopping remifentanil. To prevent a pain gap and hyperalgesia after infusion ends by ensuring other analgesics are already active. Manual infusion or TCI. Manual infusion 1. Uses weight-based rates 2. Requires frequent clinical titration 3. Helpful when TCI hardware models are unavailable. TCI. 1. Pump uses a pharmacokinetic model to test plasma or effect site concentration 2. Not a direct measurement of brain concentration 3. Model choice and patient covariates matter. TCI improves repeatability, not clinical judgment. Pharmacokinetics in one picture. Bolus 2. Central compartment 2. Peripheral distribution 2. Elimination. To show that injected drug first enters blood, then spreads to tissues, then is cleared, which explains onset and offset of effect. A plasma target and an effect site target are different. Effect site targeting introduces a modeled equilibration delay. To clarify that plasma concentration does not equal brain concentration immediately, targeting effect site accounts for time needed for drug to reach brain. Key modifiers: age, frailty, cardiac output, severe illness, interacting drugs and model population. To indicate that patient factors and model selection affect drug handling, so dosing must be adjusted to individual characteristics. Practical adult starting ranges. Illustrative educational ranges, not a prescription. Start lower and titrate to response. To emphasize these are teaching examples only. Actual dosing must be individualized and adjusted based on patient response. Propofol ECI. Induction commonly around 3 to 6 mcg per milliliter, individualized. To provide enough concentration to achieve loss of consciousness, adjusted for age, weight and co-administered drugs. Maintenance often about 2 to 4 mcg per milliliter, depending on adjuncts and stimulation. To maintain unconsciousness during surgery, with lower needs when analgesics are used and higher needs during intense stimulation. Remifentanil. Effect site targets commonly 1 to 6 ng per milliliter, titrated to stimulus. Give flexible pain control by matching dose to surgical intensity. Manual infusion often approximately 0.05–0.3 mcg per kilogram per minute. To offer a weight-based rate option when TCI is not available, allowing steady analgesia. Use local protocols, product information and validated models. To ensure safety and compliance by following approved institutional guidelines and manufacturer recommendations. Induction sequence. 1. Apply standard monitors. Establish dependable IV access. To detect changes early and ensure reliable drug delivery, since TIVA depends entirely on IV route. 2. Prime and trace every line. Confirm pump settings. To prevent air disconnection or programming errors that can cause awareness or overdose. 3. Pre-oxygenate and plan airway rescue. To maximize safe apnea time and have a backup plan if airway management becomes difficult. 4. Start analgesic component, then titrate hypnotic. To blunt response to laryngoscopy and allow smoother induction with less hypnotic requirement. 5. Confirm loss of consciousness and ventilation. To ensure adequate depth and ability to ventilate before proceeding to airway instrumentation. 6. Secure airway. Administer NMBA only with a plan for PEG and quantitative NMT. To avoid awareness with paralysis and to monitor depth of anesthesia and completeness of neuromuscular block objectively. Maintenance. Closed-loop thinking. Continuously integrate. Stimulus. Incision, traction, pneumoperitoneum. To anticipate changes in surgical pain level and adjust analgesia before sympathetic response occurs. Physiology. BP hour, ventilation, pupils, movement. To use clinical signs as early indicators of light anesthesia or inadequate pain control. Brain signal. Raw EEG, spectrogram, processed index. To objectively assess depth of hypnosis and avoid both awareness and of depth. Delivery, pump, pressure, syringe volume, IV site. To verify that drugs are actually reaching the patient and detect line failure or disconnection early. Change one major variable at a time when possible, and reassess after equilibrium. To allow clear interpretation of cause and effect and avoid confusion from multiple simultaneous changes. Depth of anesthesia monitoring. Processed EEG is particularly important when TIVA is combined with neuromuscular blockade because movement is suppressed and end-tidal anesthetic concentration is unavailable. To provide an objective measure of hypnotic depth when clinical signs are masked and no exhaled agent concentrate exists to guide dosing. Use the index as an adjunct, not a diagnosis. Inspect signal quality, raw EEG and trends. A commonly used adult BIS target is 40 to 60, but interpret in context. To avoid over-reliance on a single number, as facts and drugs can affect the index, so waveform and trend review ensures accurate interpretation. Infusion System Safety Bundle. Before induction. Dedicated, labeled lines, anti-siphon and anti-reflux protection where appropriate to prevent inadvertent bolus, siphoning or reflux that can cause under or over delivery of anesthetic. Confirm concentration, patient covariates and target to ensure the pump calculations are accurate and dosing matches the intended drug and patient parameters. Use a pump with visible alarms and battery backup. To allow early detection of delivery failure and maintain infusion during power interruption or transport. Check connections from syringe to cannula to avoid disconnection, leak or occlusion that would interrupt anesthetic delivery. Keep a rescue plan. Alternate IV access, manual bolus strategy, volatile backup if available to enable rapid restoration of anesthesia if the primary infusion fails. Treat unexplained lightening as possible delivery failure until proven otherwise. To prioritize patient safety by assuming technical failure first and acting immediately to restore anesthetic depth. Preventing awareness. Risk rises with TIVA plus NMBA, difficult IV access, interruptions, equipment failure, hemodynamic intolerance, reduced drug dosing and inadequate monitoring. To highlight situations where drug delivery may be interrupted or insufficient, and where paralysis masks signs of wakefulness. Mitigation. PEG when indicated. To provide objective feedback on hypnotic depth when clinical signs are unreliable. Frequent IV site and pump checks. To detect disconnection, extravasation or pump failure early before awareness occurs. Avoid unnecessary hypnotic interruption. To maintain continuous brain concentration of anesthetic during the case. Document targets, alarms and responses. To ensure traceability, accountability and consistent management among team members. Ask about awareness postoperatively when clinically appropriate. To identify possible awareness events early for support, analysis and learning. Hemodynamic management. Propofol-related hypotension is often multifactorial. 1. Vasodilation. To explain drop in blood pressure due to relaxation of vascular smooth muscle reducing systemic resistance. 2. Reduced sympathetic tone. To note decreased central drive leading to slower heart rate and lower vascular tone. 3. Relative hypovolemia. To consider that vasodilation unmasks underlying fluid deficit, especially after fasting or bleeding. 4. Excessive depth or opioid effect. To recognize that too high propofol or remifentanil concentration can depress cardiac function and vascular tone. Response algorithm. 1. Verify depth and infusion delivery. To ensure hypotension is not from awareness gap or pump error before changing therapy. 2. Assess volume status, bleeding and ventilation. To exclude common reversible causes like blood loss or high intrathoracic pressure. 3. Reduce hypnotic target if excessive. To lighten anesthetic depth when PEEG and clinical signs suggest overdose. 4. Treat vasodilation with appropriately titrated vasopressor. To restore perfusion pressure while maintaining adequate anesthesia. 5. Reassess, not merely chase the number. To focus on tissue perfusion and overall physiology rather than just blood pressure value. Emergence and postoperative analgesia. 1. Reduce hypnotic with falling surgical stimulation. To allow gradual lightening as pain decreases toward end of surgery and facilitate smoother emergence. 2. Stop remifentanil early enough to establish longer-acting analgesia. To avoid pain gap after stopping ultra-short-acting opioid by ensuring other analgesics are already effective. 3. Use multimodal analgesia, paracetamol, acetaminophen, NSAID when suitable, regional techniques and carefully selected opioids. To provide pain control with fewer side effects by combining drugs with different mechanisms. 4. Confirm normothermia, ventilation and quantitative neuromuscular recovery. To ensure safe emergence with adequate temperature, breathing and reversal of paralysis. 5. TIVA eliminate postoperative respiratory depression or pain. To remind that ongoing monitoring and analgesic planning are still needed despite rapid recovery profile of TIVA. Special populations. Pediatrics. Developmental pharmacokinetics and model selection are crucial. Secure access and use age-appropriate dosing monitoring. To account for maturing organ function and different body composition that alter drug distribution and clearance in children. Elderly frail. Lower initial targets, slower titration, increased sensitivity. To reduce risk of hypotension and overdepth because elderly have reduced clearance and higher brain sensitivity. Obesity, weight scaler and model selection require care. To avoid overdose or underdose by choosing correct weight descriptor and validated model for body size. Cardiac shock. Reduced clearance and exaggerated hemodynamic effects may occur. Titrate conservatively. To prevent profound hypotension and accumulation when cardiac output and liver blow are low. Pregnancy, hepatic, renal dysfunction and neuro cases require local expert protocols. To ensure safety in complex physiology where standard models may not apply and specialist guidance is needed. Case challenge. Sudden, light, anesthesia. Scenario. During TIVA with NMBA, BP and hour rise, this increases, the pump appears to be running. Immediate priorities. 1. Call for help and communicate concern. 2. Check IV patency, pump status, syringe, tubing and connections. 3. Check drug concentration, target and patient entry. 4. Increase hypnotic cautiously while treating stimulus and physiology. 5. Consider alternate IV access and backup anesthetic. 6. Document event, postoperative assessment and follow-up matter. Take-home checklist. Right patient, right model, right target. To ensure the pharmacokinetic model and target concentration match patient characteristics for accurate dosing. Right line, right concentration, right monitor. To confirm intravenous delivery is reliable, drug preparation is correct and monitoring is appropriate to detect problems. Right analgesia, right NMT, right rescue plan. To provide adequate pain control, appropriate neuromuscular blockade monitoring and a backup plan for failure. TIVA is not simply propofol on a pump. It is a complete delivery and monitoring system in which pharmacology, technology and vigilance must agree. To emphasize that safe TIVA requires integration of drug knowledge, equipment function and continuous clinical vigilance, not just running an infusion. Selected evidence and resources. Chinese Society of Anesthesiology Clinical Practice Guideline and Consensus Recommendations on TIVA 2025. Association of Anesthetists Guidance on Accidental Awareness and Processed EEG in High-Risk Settings. Practical TIVA Guidance. Pump Programming, Line Security, PEEG and Remifentanil propofol use. Recent reviews comparing TIVA and inhalational anesthesia. Use institutional protocols and current manufacturer instructions. Doses shown are educational examples and must be individualized. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.